Hello, everybody. My name is Ryan Romalia, and I'm a grateful recovering addict who has found 4 years of sustained recovery by the grace of God. Thank you. So, I'm just going to give you a little bit of my story. I was a lost kid who chose to do something that put me behind bars, in institutions, homeless, living under bridges, losing my mind, and ultimately killing myself several times over the course of a month in the height of my using. I got to the point where I was injecting deadly chemicals directly into my body and hoping that I wouldn't wake up. I really didn't believe that there was another life for me. I didn't want there to be another life because I wanted to be taken away from my suffering. I didn't want to be miserable. I didn't want to be in pain. I didn't want to be alone. I do credit these institutions for saving my life when I refused to save myself, or I wasn't able to. I did not have the will to save myself. So over time, I ended up getting into the recovery community that I credit for saving my life. I met people who had been through what I've been through. I didn't feel alone. I felt like they understood me. And now I get to have the privilege of working in the recovery community as a recovery coach, peer support specialist, and an advocate. And I work for a couple agencies. I worked for First Mile Active Recovery in Fort Kent and AMHC. And so grateful for it today. So, I'm not going to get into too much details about my story, but today's topic is building a recovery community, a recovery-ready community, and I'm just going to talk about some of the things that worked for me. One of the first things that I learned was the importance of connections. You know, they say isolation is the enemy of recovery. That's what I did. I took myself out of the world because I didn't want to be here, and I never got the chance to grow and become who I ought to be because of it. And eventually, the recovery community embraced me, and eventually I started to listen to these people who had what I didn't have. And because of that community, I was able to find who I was. So connections are so important, family, people in the recovery community that are there for you and they're not judging you. It's so important. The second one I want to talk about is recovery housing, or just a place for people to go, a center or options in the community for people to find a place, like I said, that you're not judged, where people understand. And that's probably one of the most important things for me, is finding people who have been through it. That lived experience, there's nothing like it. And also, these spaces are often run by people who, like I said, have been through it, so they understand and they want to understand. Most of the places that I've gone were peer-led centers and locations, and it was just like amazing to see people that wanted to go through these things with me instead of just telling me what I need to do, because I wouldn't listen anyway. The third point for me is education, and I added something into it, just like job and life training, understanding what's important about taking care of ourselves as humans. Because, for me, it felt like in school they wanted to teach me all these skills that I didn't care for, or they weren't the priority for me, but I couldn't find a place to learn about what I needed to for myself. And so today I try and, talk to people in the education system and in the community that have a voice in these places. And a lot of them agree that they should be teaching life skills in school and, what's going on in our brain, especially those in addiction, just understanding why our brain does what it does and makes us the way we are. The fourth one was, recovery support young, or even like I said, in school. If we can teach people this younger, they'll be more likely to take this as their identity. And when I got older, I started to get in my own way. I didn't want to do anything anyone told me. But when I was younger, I was very impressionable and there wasn't much of my thinking to get in the way. I kind of just lived. Now it's like I overthink everything, and they call it a thinking problem. So I think that it's so important for us to teach kids, even before they fully understand it, about what's happening in our brains. And then the last one I added in was spiritual purpose, or a higher purpose. And for me, this is the most important one. And I don't mean necessarily a religious purpose, but spiritual for me is like the essence of who I am. And I didn't know who I was. And what I thought of spirituality was something outside of me that wasn't me. But in recovery, I learned that spirituality is who I am. It's all the things in my life that are connected to me. And my journey to find my spirituality was my journey to find myself. And so really it felt like the gift that I was given was the gift of myself. And I'm just so grateful today that I get to know who I am. And I made it a mission to offer my service to everyone I could in a similar situation, to try and help those who are still suffering, because that's what they did for me. And so I just feel like it's what I need to be doing. And I'm so lucky that I did, because now I know how important and crucial it was for me to do this. It wasn't just about me anymore. And somehow it came back to me because I didn't make it about myself. Of course, I fought my pride the whole way through, but I really do just think that one of the best things we could do is learn about ourselves, learn about what's going on, and then learn who we are. And in a community that is collaborative in that way, we all can be creative in how to do that. Everyone has different ideas, but when we come together, those ideas become new anyway. And so if you ever think of something that you could offer this community, whether it's local or statewide or nationally, whatever you think of that might help is a valid and worthy idea, and it should be explored. So let's collaborate, Ultimately, to me, I think it's important that we plant seeds that will help people grow and heal, because we're all recovering from something. On that note, I'm probably running close to my time, so I just want to thank everybody for listening. I want to thank Danielle Farino for starting First Mile Active Recovery, for coming in that AA room and just, sharing her story and letting me in to her mission in the community. It's been a lifesaver. I don't think I'd be here today if I didn't have that. I also like to thank AMHC for allowing me to provide more services to the community, and thank Janet Mills and Gordon Smith and the legislators of Maine for doing what they're doing. That's it. Thanks, guys.
Thank you, Ryan. And now I'm going to let Mark Lefebvre introduce himself. Thank you. Are you using this?
No, I'm not.
Okay.
I'll do stand-up if I use that. And you don't want that. Good morning. How's everybody doing today? You guys all in the right room? I'm scanning the room here. I got one friendly, two friendlies, people I know, many friendlies. All right. My name is Mark Lefebvre, and I am a person in long-term recovery. And for me, that means that I haven't found it necessary to pick up a drug or a drink. God willing, this next month of August for 13 years. And thank you. And the amount of years are less important than the fact that I'm sober today. And so I just want to make that. So is everybody's in the right room, okay? And everybody can hear us? I know that other room is loud, so you want me to speak louder? Okay. All right. So what we are going to do here today is to have a discussion on a path forward to building recovery-ready communities. And how many people here have experience working in a community where there's some level of capacity to help people that are struggling with either addiction, mental health, and so forth? So, good. Before I get started, I wanted to introduce a couple of people here that were very, very instrumental in this work and in the book that I'm signing downstairs. And if you didn't get a copy of the book, I'll be downstairs, and if you want to buy one, that's fine. If you just want to talk, that's even better. So, but I want to recognize Larry McCullough, Dr. Larry McCullough. He is the executive director of Pine Tree Institute. And I'll reference Larry and the work that the Greater Portsmouth Coalition does later on in this talk. And I also want to introduce Jennifer Edwards, who is doing heroic work in the communities of Lewiston and Auburn in this space. So Jennifer, thank you. And if I miss somebody, it's not because I don't like you, it's just that I don't see you. All right, so let's get going here. So let's very little bit about me. I identify myself today not only as being a person in recovery, but I have a lot of passions. My family, of course, that's me fly fishing in Alaska. I love fishing. I was talking to somebody here, the gentleman Alan from Sangerville, and distraction in the back of the room, that I go up to Moosehead Lake at least 2 or 3 times a year. And I go up to do fly fishing. I won't tell you the rivers that I fish on up there in case there are any fishermen in the room. And I go up hunting, and I just go up there and do a lot of hiking and camping and so forth. So I spend a lot of time up there. And I'm also a radio DJ. I do a punk rock garage radio show every Sunday mornings. It's kind of my alter ego. And it's just a great artistic outlet for something that is not related to the work I do. I've been doing that for 13 years too. So I think there's a coincidence between finding something that you love. But before we jump into this material here, a lot of comments this morning from Dr. Squirrel and Dr. Va and from Ryan Hampton about the power of community and community connection and so forth. And we heard it through Ryan's discussion this morning when he talked about how important community was to him. So we're going to talk about that. But before we do that, I'm going to scare you. Whoop, I missed one. Nope, I didn't. I'm going to scare you in the next chart. So what we're all going to talk about today is understanding addiction with a heavy emphasis on community. So we'll talk briefly about addiction as it relates to the individual. I think we all get that. We know about ACEs, we know about the root causes of trauma, but I'm going to bring that forward here for context. But really what I want to emphasize today here is this concept of the community as a patient. And then we'll spend a lot of time talking about building coalitions to address things like addiction, behavioral health, and so forth. When I say we, the people that helped me articulate what we characterize as what constitutes a recovery-ready community, what are the elements? And then I want to spend a significant portion of the time here talking about the Greater Portsmouth Recovery Coalition, which is a living and breathing example of starting from the back of a napkin to a thriving recovery-ready community with key sectors all participating in that. All right, I told you I was going to scare you. This is not the Unabomber. This was 60 days after I got clean and sober, and I got out of treatment. And the beard quickly came off. The only reason I show this is this is not the person who's up here talking today. This is a person who was, even with 60 days under his belt, scared, didn't know where he was going to go to get help, had a list of 12-step meetings in the area. There was no recovery center at the time. There was no recovery housing at the time. There were no peer recovery supports at the time. MAT did not exist in the state of New Hampshire at the time. And harm reduction, I don't even know if anybody's really talking about that outside of perhaps, CDC and, those types of organizations. So with that as a backdrop, I want to explain to you kind of a growth of a group of individuals that came together to address those gaps and those barriers that existed back in the time. So understanding addiction, everybody here understands what addiction is, otherwise you wouldn't be here today. We learned a little bit today about the impact to affected others, and what I'm talking about here is, and there's a lot of detail on all of this stuff that you'll find in the book, and please let me sign your books. And then, but I'm going to specifically focus on addiction as it relates to the community, and by that I mean things like public safety, public health, economic development, education, crime, and those types of things that affect the community when addiction takes its toll. And by the way, if somebody has a question, make sure you write it down or something, because I want to leave time at the end for questions without interrupting your lunch. So, addiction, as we know, is rooted in trauma. Dr. Va talked about adverse childhood experiences and the impact of high ACEs score as a predictor, as a population, to downstream health issues, behavioral issues, and so forth. So, but adverse childhood experiences not only happen within the home, they happen within the community in the form of, I'm going to cite a very painful example of what transpired almost a couple of years ago in Lewiston rather, as a perfect example of something that affects the whole community. And for the environment as well, as we see this week in Texas, as an example, trauma as a result of a natural disaster, perhaps poor planning and readiness and so forth. So addiction and trauma can occur and affect not only the individual, but the family and certainly the community. However, we can interrupt the impact of that trauma, and Dr. Va mentioned this morning I think it was either her or Dr. Scroll, I can't remember which of the two, I wrote it down, but I can't remember it, talked about how when they surveyed students that were self-reporting high ACEs, that with the impact of either a parental and even more importantly a non-parental mentor being felt like they were worthwhile and that they were involved and that their lives were meaningful, they could reverse some of the downstream issues that may face them as a population. And that is achieved through positive childhood experiences. If you haven't heard of these, I recommend that you write down the name Dr. Christina Bethel, Bethel. She's done pioneering work on offsetting the impact of high ACE scores with positive childhood experiences. And then also social determinants of health was also discussed this morning with regards to being connected, being involved, living a meaningful life, having meaningful things to do, and not necessarily putting the burden on the schools, but after school items, weekends, and so forth, so that our kids can feel connected. So I'm going to jump into this a little bit more detail now. So building resilience involves three major components based on the work that we've done in the research that I've investigated as part of this work. Is the community has a connective tissue, and connective tissue in the context of a physiological or anatomical, we have tissues that connect to bones and so on and so forth. Communities have similar connective tissues, whether it's culture. In my hometown, where I grew up in central Massachusetts, we had French Hill, we had Italian section of town, we had Hispanics section of town, yet we all played in the same Little League teams. We all played we were all in the same Boy Scouts. We all went to the same junior high and high school. We called it junior high back then, so I'm showing my age, not middle school. But there was a culture. There was something that kind of connected the community together. And then from that, we'll talk about what is a resilient community, and then what does trauma-informed community engagement look like. So the connective tissue of a community. Can anybody give me some examples, and I did tell you I was going to ask questions, of elements of a connected community, maybe where you lived or where you grew up? Just shout it out. You don't have to raise your hand. Go ahead, Larry.
Well, you mentioned a couple, and another interesting one is Rotary Clubs.
Rotary clubs. Excellent.
Balloon festivals.
Excuse me?
The balloon
balloon festivals, any activity that brings people together to communicate and engage with other people in their town. Anybody here talk a little bit more or give some examples on what the benefits of a connected community might be?
Access to more resources.
Access to more resources. Access to resources, for sure. Molly?
Intergroup dialogue.
Intergroup dialogue to solve a common issue or to celebrate. Doesn't have to be necessarily a negatively impacted. Anybody else? Relatability. Social capital. Bingo. That's the one that's. Are you a plant? All right, so let's talk about that. So community resilience, this definition, community resilience is a measure of the sustained ability of a community to respond using their available resources and to withstand and recover from adverse situations. And I should have cited the source of that, but it's certainly cited in the book. Does that make sense? Coming together, using our available resources to address and recover from adverse situations. I would also in there say that in my experience in working and talking with others to inform the book, that preparedness is also something that we can do to build a resilient community. So, does anybody here know Danielle, is it Parent or Parent? Parent, Danielle Parent. She led the response team for the Lewiston community following the events. And I interviewed her and asked her, she came and she spoke at one of Pine Tree's conferences, and I pulled her aside and I asked her some specific questions about, how are they doing it? And what she shared with the group there at that presentation is, number one, you need to know your community. And by that, not pretending that you're something other than what your community identity is. So for instance, and community, by the way, doesn't necessarily mean a town or a city. It could be a county, it could be a neighborhood. And so knowing your community involves, what are your cultures? What do the people in your town, what do they care about? What do they do in their free time? Where do they work? Without being intrusive or nosy, but know the people in your community, know their culture, and this is in the context of responding to a tragic event. So you want to know your community so that you know what their issues are, you know what their problems are, you know what their troubles are, you know what they care about. Understand the impact. Understand, so in the context of substance use disorder, what's the impact? I mentioned a few earlier, public safety, public health, economic development. That's at the community level. In the family, it's betrayal, it's confusion. You heard Alan and Katie talk this morning from both sides of the coin, as somebody who was addicted to drugs and recovered, but how the family is impacted as well, and they need to have their own journey of recovery. Know who they are and how they are impacted. And I think that's where the power of peers come in, peer recovery, peer support, and peer organizations. Safe places to provide support. You don't want to re-traumatize somebody in an effort to help them. And I'll give an example of this. There's a recovery center, community recovery organization, an RCO in New Hampshire. I won't mention which one they are, but their intent was to do the right thing and to broaden their services to a broader population. And what that involved with is creating a section of their recovery center for syringe distribution and turning a blind eye to safe usage, even though there wasn't a safe usage program in the state of New Hampshire. And as a person in recovery, I think I would be threatened to go to the recovery center if I knew that people were bringing substances on site. It's one thing for somebody to be coming in and they may be still high or they may be still drunk, and a peer would approach them and sit them down and try to help them. But if somebody is in early recovery, I think that's problematic. So I would characterize that as being an unsafe place to provide support. And then prepare for the challenges, both seen and unseen, going forward. So trauma-informed community engagement is safe physical environments, trustworthy relationships, empowering people through opportunity. In other words, get people to the table. There's a saying in some of the youth prevention programs that we bring youth in to be part of the coalition, nothing about us without us, that type of a mantra. This is what that means here. Give people who use drugs, give people who are in recovery, give people who may have a different point of view, give them a seat at the table, give them decision-making seats at the table, get them involved so they can bring other people in and bring a perspective that is not necessarily from the so-called experts from all the sector within the community. Peer support. And you're going to see this throughout this talk, is the power of peer support. I was a certified recovery support worker earlier in my recovery, and it helped keep me sober to be able to talk with people about their challenges because I had been there. And it's different from going to a 12-step meeting where there's a kind of a protocol. Peers can talk the same language, they've been down the same path, and it definitely lowers the power differential between parties. And then cultural diversity. Make sure that your engagement at the community level includes people that are, I wouldn't say marginalized per se, but are not necessarily participating because their culture is different. And again, I go back to the example of Lewiston. Lewiston is probably my favorite city in the town of Maine. And the way that they welcome in folks that are seeking asylum, refugees, people of color, and so forth. And as a result of that, they've got those same individuals, some of them working in leadership jobs in the community. They own their own businesses. They're on, I think two of them is on city council and so forth. So they're really integrating that cultural capability within the diversity within the community. So let's talk a little bit about recovery, and again with an emphasis on the community here. We all know what individual and family recovery looks like. But this is from 2012. Admittedly, it's a bit dated, but this is what SAMHSA says about recovery. Recovery is a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. I think most of us have probably seen this at one time or another. So, what does that mean? I emphasize three. I'm going to go back one. Which button is this, the red arrow? Yep. So I want to focus on three elements of this statement: process of change, self-directed, and reach full potential, because those are the things that kind of pop out at me when I look at that definition. Whoop, let me back up again. Got too far ahead of myself. I'm going to be asking questions on this one. There we go. So process of change. You'll notice the graphic. It's a pathway. It's not a destination. That's intentional. The journey is what's important. What do we learn along the way as we go into recovery? What does the community learn along the way as it's on its path of recovery? And again, using the Greater Portsmouth Recovery Coalition as kind of an example, they're continuing to expand and grow and reprioritize and work at a rate and pace that makes sense for the community coalition that is now in its, I think, 5th or 6th year of operation. And we're going to go through that in a little bit more detail. Self-directed. We don't want somebody from Washington telling us how we're going to do recovery at the community level in Machias, as an example. It's just, so self-directed at the community level means we have the power and we have the mission, and we also have the obligation to help individuals that are struggling with addiction. And then strive to meet full potential. I'll go back to those other tenets that I talked about: public safety, public health, education, workforce development, and the economic development. So what's the full potential? But create an environment where people and individuals and families can reach their full potential within that community. I'm going to skip this. We heard a lot about that this morning. One thing I will note as somebody who is in long-term recovery, my path to recovery was significantly faster than recovery of my family, my wife and my adult children. And they face the barriers of stigma that we face because they don't have all that recovery in their head that we get either through treatment and recovery and sober living and 12-step meetings and so forth. They don't have all of that capacity, and they still feel a lot of shame and stigma about raising their hand and saying, hey, my husband used drugs for 40 years, along those lines. So they face a lot of the same barriers, and there's not as many resources out there that we have. It's growing, however. So the community as the patient is really the fundamental element that I want to talk about today, and that's basically when an individual is a patient, they get wheeled into the ER or they go see their doctor. There's a triage. There is a nurse or somebody doing some sort of triage. We see specialists. We see general physicians. We see pediatricians for our kids and so forth. Though the community has the same responsibility, I would say. The community has the same responsibility to provide those types of functions to their citizens for the reasons that I stated earlier about community health. And the community stakeholders sort of serve as the surrogates of the medical professionals that we see as individuals. For example, by sectors, I mean health department, law enforcement, first responders, the school system, Chamber of Commerce, treatment or recovery assets that are in the community, recovery centers, the library, so all of those sectors, all of those individual organizations at the community level, community-based organizations, those are the stakeholders that provide that level of support to the community as the patient. Self-directed, as I mentioned earlier. So recovery capital is used a lot. We heard a lot, capacity capital, but recovery capital takes place at the personal level, at the family and societal level, as well as the community level. We're going to talk specifically about community recovery capital as we go forward. So personal, self-awareness, you can read that. In terms of recovery capital, again, Faces and Voices of Recovery is the source of this information. They've got a great website and a lot of newsletters and resources. By the way, Faces and Voices of Recovery. Family and social recovery capital, again, relationships, connections, bridging being able to have access to things, and then social engagement. That's how you build a recovery capital at the family level. So at the community level, we start talking about the organizations and the assets and the community-based organizations that come together we start talking about things like treatment, recovery, prevention, harm reduction, those types of things. Those are the assets that the community should, as an obligation to its citizens, provide as a service and as a way to build recovery capacity within the community. So let's talk a little bit about coalitions. Anybody in here on a coalition? Anybody here ever been asked to participate in a coalition? All right. It's gonna be tough. It's okay, you're still in the right place. Actually, that's a good thing because you don't come in here with any preconceived notions on how to. So building the coalition, and again, this information is based on work that when I was working at Pine Tree Institute, and we've got other members here of the Greater Portsmouth Recovery Coalition in the room, but it's based on the lessons learned over that period of growth. And we're going to take you through I'm going to take you through the phases of that in just a minute. But it's also through conversations that I've had in Lewiston, Auburn with their collaborative. It's also based on input that I receive from Machias and the work that they're doing up there with Recovery Friendly Workplace, and the York county work that's going on in building a recovery center and building elements of a recovery-ready community there. And then early on, some of the work we did with the Kennebunk area, substance use disorder, what do we call it? It was the coordinated response to substance use disorder. Thank you. So building the coalition. What I'm going to talk about today is why is a coalition important? Why is a coalition approach important? Because no individual within the town has the power or the resources or the mandate, to address this issue. I'm going to talk about a framework, talk about the importance of funding for the coalition, and by funding, that's for coordination and facilitation. Developing a set of rules of engagement. How frequently is the coalition going to meet? Who's going to provide minutes? Where do we store documents? Do we follow Robert's Rule of Order for the coalition meetings? That type of thing. Virtual, in person, who chairs, who doesn't chair, that type of thing. So, and then documents and record keeping. These are the critical elements at a very high level of building a coalition. So why do we want to form a coalition? Number one, it provides a common form of community engagement. In other words, sectors and people from parts of the community that would not normally work together have an opportunity to engage on a common problem. One sense of urgency that, in this case, is substance use disorder. It could be climate change. It could be smoking and vaping in schools. That whatever that issue is, it brings everybody together to form a community engagement model. And then it also creates an environment where leadership and responsibility for the coalition is shared. Everybody has a say, everybody has a hand in it, everybody has a responsibility as they participate in it. So, what are the minimal requirements of a community coalition? Number one, you need an influential champion, somebody who's going to raise their hand with passion. When I think of an influential champion, I think of somebody like Gordon. Somebody that's got connections, somebody has the passion, and somebody has the characteristics and leadership styles that can navigate a group of people towards a common thing. At a community level, this could be a city councilor, it could be a parent, depending upon what the cause is, there needs to be an influential champion that has connections to other resources. Adequate financial resourcing. This is the piece, and I think I might even cover it in more detail a little bit later. Let me do a time check here. We're doing good. 11:15, right? Where is she? We're doing great. We're doing great. All right, adequate financial resources. Let me talk about that one for a second. And the financial resources are not only for the coalition itself, but the parties that come together to address a common problem. It doesn't necessarily mean money. It means the organization that you work for or the function that you do within the community is giving you space to participate on this capital, on this coalition. So that's one form of financial resourcing. In terms of money, what we've learned is that without having an organization or a leader who is specifically paid to facilitate or coordinate the coalition, then it's not as successful. And I'll talk about why coalitions fail in a little bit more detail. And then this came out of an interview I had with Lisa from Tamarack Institute when they were doing the work. Are they still doing the work in Lewiston? Okay. Tamarack Institute's out of Toronto, and they provide very, very effective leadership and change and community building programs and services as consultants. But the thing that she said was that is the most critical thing is, number one, you have to have a sense of urgency on one thing. And in some cases, it could be something general like economic vitality within the community. In the case of substance use disorder, a sense of urgency. In other words, this problem is so important that we are going to allocate people and get people to come together to agree that that's the issue, and we're going to continue to work together to solve that issue. So coalition framework, number one, and this goes back to what I was talking about earlier when I had the conversation about Danielle Parent, is really to understand your community. So who are the people that should be represented? Who are the functions? What are the functions within the community that need to be represented? When do they need to come on board? Because not everybody needs to come on board at the beginning, as you'll see with the Portsmouth example. Identify potential coalition members. What's really, really important is that these coalition members are decision makers. Because we've all played telephone tag in grade school. If you have people that report to somebody else that's a decision maker, that person's not going to be empowered to make decisions on the fly, on the spot, without getting permission to do so, and that drags things, creates a time lag and miscommunication in some examples and so forth. So it's really important that individual be a decision maker. Orient all the members to the problem that you're trying to solve. In our case here, substance use disorder, and the use of evidence-based practices. The reason there is that people have, like me and others, and probably everybody here, we have our own biases. We're human, we have biases. Some of that is due to just a lack of experience, some of it's lack of education on the specific issue. Some of it could be arrogance, but not all of it is malicious. So orient people to the evidence-based practices that are going to support the solutions that you're going to go forward and try to implement. And then, like I said earlier, develop coalition rules of engagement. Why is it difficult? Stigma. In the case of substance use disorder, some communities don't want to admit they have a problem for whatever reasons. And we had that same experience in a New Hampshire town where we tried to expand the coalition to include some of the neighboring towns. We couldn't get them to the table. They sent an admin person from the hospital who was responsible for the what do they call it, China, the needs assessment that they do every 2 years. That's the representative, and a police officer who was a resource officer at the high school. And we just couldn't do anything with that. They didn't think they had a problem. Lack of common understanding about the problem. That's why I talked earlier about using evidence-based and communicating that in a way that you're meeting people where they're at. You're not confronting them with all this science. Where to begin? This is the whole motivation for me in writing the book and the work that we did at Pine Tree Institute with the Greater Portsmouth Recovery Coalition, is to document what we did along the way and put it in a format that people that live in other communities can know where to start. Not every town or community has the same entry point. They may have a different approach. Everything's going to be different depending upon what the culture and the community needs are. But knowing where to begin and how to progress from where to begin, how to do the triage, how to prioritize, pick 2 or 3 things that you're going to focus on first. I said something already about the denial of that there's a problem in the first place. Lack of key decision makers, that is certainly one of the key things that cause coalitions to struggle. Poor communication. In other words, what happens at the meeting is all great and fine, but nobody's taking minutes, nobody's documenting, nobody's sending the minutes out, nobody's sending the agenda and arranging an agenda ahead of time so people can prepare for it. So when you're at the meeting, you're doing productive things based on that agenda. All of that communication, outbound communication to let parties know what you're doing. So the sectors that are supporting your participation on a community coalition, they understand what's going on. Lack of capacity. Some organizations may have more capacity than others. Some towns and communities may have more capacity than others. That's why one of the things that we did in Portsmouth that was really important is we did a needs assessment and a set of priorities right up front so that we knew what we could address and we put on the back burner, not that we weren't going to do it, but we were going to revisit it when we had more capacity to do so. Lack of leadership, that goes back to this having somebody that facilitates, have a party of the coalition that is responsible for facilitating and keeping this thing moving forward. And lack of sustained funding. How many in here live by grant cycles? Let's get them up. Anybody here frustrated when grant cycles don't align with your program continuity? Yeah, okay. You're still in the same room. So where to begin? Get the right representation. Specifically, that you go out and you recruit sectors, again, who are decision makers and who represent a stake in the problem that you're trying to solve. So for substance use disorder, I mentioned a few of them, law enforcement, first responders, the hospital, education, Chamber of Commerce, recovery assets, treatment assets, and so forth. Make sure that their decision makers are present at the coalition. Sustainability, seek multi-year funding sources. And that is sometimes difficult to do with grants, because grants sometimes, especially through foundations, are reviewed on an annual basis. One of the things that we did really well is we communicate and involve our funders. So we do readouts, we go visit them and show them the progress we made so they can see the progress of their investment in the community. Coordination, I beat that one to death, but I'll say it again. If it's no one's job, this is Larry's quote, by the way, it's no one's job if it's everybody's job. Because no one has the full-time job of being a coordinator unless they're leading the coalition. So if somebody is a recovery, representing as a recovery coach from a community recovery center, and they sign up and volunteer that they're leading it, they're not paid to do that. It's in conflict with their job. There may be examples where organizations are willing to, put somebody either on a sabbatical or pay them for their time to lead a coalition. The Dover Mental Health Alliance, for instance, the leader of that is paid partially to lead that coalition. So you need somebody that's got an independent function and mission outside of their day job to lead the coalition. So what is a recovery-ready community? Anybody know? Good. You're still in the right place. A few questions that I want you to think about as I go through the next part of this presentation is that should the coalition, should it be self-defined by the community? We applied the SAMHSA definition of recovery here to the community. Should it be self-defined? Does recovery look the same in every community? Of course not. How would the community measure readiness? How do you measure progress? Should there be, or is there a standard model, a numeric model? If you get a score, you're a recovery-ready community. And then what are the minimum elements of a recovery-ready community? We're going to cover all of this. So let's break it down. SAMHSA defines a recovery-oriented system of care. I'll let you read this. I don't want to read it. For those that are, I think the slides are being showed simulcast. Yep. So you guys get a chance to read this. Coordinated network, et cetera, et cetera. This was written in 2010. This is from DHHS, U.S. Surgeon General report from 2016, an integrated system of care that guides and tracks a person, et cetera. And then the third one that I'm going to put up here is from author Elizabeth Barden, who led this group to do anybody here familiar with the trauma-informed, recovery-oriented system of care document? You should Google that. It's a group of counties in Indiana that were led by the National Council for Mental Well-Being. It's now the National Council of Behavioral, no, it is Mental Well-Being. Anyway, it was 2024. There's a URL on the chart. I don't know. Oh, you can actually hit the QR code. I think it might take you to that document, or at least a link to that document. It is a cookbook on how to learn. It's a learning readout of what they learned by bringing all of these counties, something like 19, 20 counties in Indiana, to come together and address addiction within Indiana. And it informs my work and informs the work that we're doing with Recovery Ready community work. So this is the one I kind of hang on to, a program, organization, a system that recognizes widespread impact of trauma and understands potential paths for recovery, recognizes signs and symptoms of trauma in clients, families and staff, and others involved with the system, and responds by integrating knowledge into policies, procedures, and practices. That's a word salad. Let's break it down. Using the Surgeon General's definition of substance use disorder, their objectives are fivefold: enhancing health, preventing the use of drugs, early intervention, treatment, and then recovery support downstream for when an individual re-enters or is in longer-term recovery. 15 minutes. Don't forget the 10-minute warning.
A few minutes ago, you were 10 minutes from your 10-minute warning.
Oh, okay. Minimal elements of a recovery-ready community. Sources for this are the work we did in Portsmouth, Lewiston, Auburn Area Recovery Collaborative, Portland, Maine Recovery Community Center, Maine Governor's Office, interviewed Gordon and others, and the Kennebunk Coordinated Response. Youth programming, harm reduction, community education, MAT, inpatient, outpatient, treatment court, recovery housing, recovery community organizations, recovery employment, access to services, reentry services, and recovery community navigators. We did not have all of those elements day one of the Portsmouth Recovery Coalition. I believe we're pretty much there in some form or fashion today. So mapping the elements of the Recovery Ready community into three columns: prevention, treatment, and recovery supports. This is just a way for me to understand and align and be able to consider all of the elements of a recovery-ready community within the recovery-oriented system of care model. This is a chart that Pine Tree Institute put together, which kind of defines in a graphic form how the Recovery Coalition can be represented. I call it the big animal picture. In the center are individuals, families, and affected others. The coalition with leadership is kind of wrapped around that in terms of providing leadership. And then we have the stakeholders. And there are others. This is not all encompassing. Recovery housing, services for the homeless, co-occurring illnesses, harm reduction, access and coordination, employment support. There are other things that could be up there, reentry from corrections. It's really up to that community to decide what's within that model. So that's what it looks like in practice. So let's break it down just a bit. I'm going to quickly go through this because I want to get to what we did in Portsmouth right now. So breaking it down, prevention, decreasing risk factors, increasing protective factors, increasing interventions. That's the model for prevention. You heard it this morning, other presentations. Harm reduction, all of you, I assume, are here, understand what this is. Harm reduction can also take other forms, by the way. If somebody's homeless and they find a shelter, is that not harm reduction? If somebody's basic needs are being met? Community outreach. One of the things that we did really well with the Portsmouth Coalition is very early on, we deployed an army of people that were trained on adverse childhood experience to raise the understanding within the community about the impact of childhood trauma on all the other downstream issues. It can address stigma, it can address misinformation and myths, preconceived opinions, and so forth. One of the things that's really critical here as it relates to stigma. Stigma in and of itself with language and so forth can be harmful, but when it prevents somebody from getting a job, finding a place to live, or getting involved, even finding their ID, getting a driver's license or getting a social security card, whatever those things might be. Stigma affects our ability to get that. So treatment, we consider treatment the ASAM model for adult addiction treatment, and you can see here the levels. I'm assuming that you're somewhat familiar with those. That's in the treatment column. And then I'm going to skip this because I want to get to the recovery supports. Here we go. So recovery supports, the third column: housing, community organization, RCOs, recovery coaches, peer navigators. Does anybody here know what a peer navigator is? Leslie Clark, who just retired from PRCC, she and I had a conversation about this, and I had a follow-on conversation with Gordon. One of the things that's missing in a lot of communities is not necessarily a peer recovery coach. It's somebody who is good at project management, that can navigate all of the resources within the community, develop relationships with them, develop a partnership to do outreach and inbound and outbound referrals and so forth. That's one of the things that it's almost like a peer recovery coach who gets certified as a project manager. So that type of a skill set. RFWs, access to services and reentry. Rural communities, NIMBYism. I go in deep dive in this in the book, but what works in Portland does not necessarily work in Sangerville. So we need to find a way to bring services to those people so that they have access. NIMBYism, everybody loves recovery housing unless it's next door. And so that's one of the other barriers that we face. So case study, Portsmouth 2016, ground zero for opioids. We were the second highest per capita overdose deaths in the country with the least amount of state funding for programs. So think about that, the least amount of money for state programs and the second highest incidence of overdose preventions. And you can see there were 3 dark blue states on the map there: Pennsylvania, Ohio, and West Virginia, and New Hampshire. So, Portsmouth Recovery Coalition. This is kind of the evolution. In 2018, started conversations. We brought a handful of people together to toss around some ideas. We weren't necessarily seeing a lot of overdose deaths in the Seacoast at that time, but usage as reported through our school systems and some of the crime that's associated with that, breaking and entering, that type of thing, and all the ancillary issues that surround substance use were on the increase. In 2019, we did a breakout group at Pine Tree. At the conference, we discussed who should be available, or who should be asked to participate, rather, to collaborate. In 2019, we launched the precursor to the Greater Portsmouth Coalition, the Coordinated Response to Substance Use Disorder. In 20 to 21, we addressed some specific focus areas. I told you before, you need to prioritize and keep things moving forward. You'll address the other issues as you build capacity. And then 2022 to 23, we expanded our focus into these other areas, such as services for the homeless, let me think for a second, harm reduction, and there were a few others. And then starting in 2023, we measured outcomes, and in 2025, we're sustaining that through regular meetings with the coalition. So this is the timeline. I just took all of that words and put it on a time chart for you to use and to consider. The bottom line here is that this is a journey. It takes time. There's no end point. You see the arrow in 2025 still goes to the right. So the initial focus we had was recovery housing, access to services, coordination of services, and recovery workforce development and education. We had a list of about 10, and we put the others aside to focus on these 5. So what we did was we developed these task forces. For each one of these, we developed a task force. Here we go. Comprised of anywhere from 4 to 6 or 7 individuals from various community sectors that were decision makers. Yep, 10 minutes. Plenty of time. That tells me I don't have to rush. We had a chair, a co-chair from Pine Tree Institute, and a chair from one of the organizations participating. We did a needs analysis. We set priorities and goals for that particular issue that we were resolving, and then made recommendations back to the leadership team of the coalition to set the agenda for the next phase of the coalition's life cycle based on the assessments that we did. So for each one of these, we had a task force. In phase 2, we kept those 5, and then we added defining and measuring outcomes as one of the focus areas so that we can start measuring whether or not the gaps that we addressed in the earlier phases were being addressed. This is not a numerical outcome. This is a table of the objectives that were set forth for that particular task force and the status of that, and then going forward, what are we going to move and work on? We included harm reduction, services for homeless, co-occurring behavioral health. We went to the New Hampshire State Board that provides all the training to clinicians in the state, and we started working with them to develop a training module that included co-occurring illnesses. So it wasn't just a mental health silo of training or a substance use disorder silo of training. We had a course that talked about integrating the two and providing that training to clinicians across the state. And then we enhanced our education and outreach. I'm not sure you're going to read this, but Molly was kind enough to provide this. This is an example. This is an example of the task force of harm reduction, which was in the category of prevention. What are the assets that we currently had, and then where were we going forward? We did this for each one of the elements of that task force. So 2025 and beyond. At one time, we had close to 25. We had 25 organizations and 75 members over the history of the coalition that has participated in that coalition. Is it every month or every other month that we meet? Every other month that the coalition meets as a check-in. How are things going within your particular focus area? Is there anything that you need help? Anything that you need to rise to the top that we can address as a coalition? So I would characterize that Portsmouth, through the work that we've done with the Greater Portsmouth Recovery Coalition, has now the capacity to support the entire continuum of care. Again, there's no destination, it's a journey. For prevention through some of the youth work that we're doing with Drug-Free Community, grant that we received from the federal government, harm reduction, treatment, and recovery support, all 4 elements of that recovery continuum of care. So, we're gonna have 5 minutes for questions. Today, I launched 7? Good. So we recently held a reception for the Greater Portsmouth Recovery Coalition at WSCA Community Radio in Portsmouth. And we had, it was a lot of fun recognizing those individuals that participated, as well as the role that WSCA played as a media partner. And at that event, the mayor who wrote the foreword was there, and he gave a presentation. So today, Portsmouth is doing some really great things. Lewiston, Auburn is doing great things. There are a number of different communities in Maine. York is starting to see some progress. A lot of people talking about coming together and addressing this. Washington County, they're doing some great things. In pockets of Maine across the entire state, rather, are doing elements of recovery work within the community. And that work should absolutely continue. But if any community is interested in formalizing a coalition and to take this to the next level, there's certainly a blueprint that is provided not only in this presentation but also in the book, again, that I'll be downstairs signing later on today. So with that, there's a QR code for my website. For more information, I'll be posting newsletters and I'm going to be doing some webinars and so forth. All right, well, thank you. I appreciate your time.